sure are aware that we are doing more and more mammography as the years pass. And if you sit back and look at why we're doing this more mammography, I'm sure you'll also come to the realization that it's because the bulk of these increased cases are screening cases. They're not women who are coming in with lumps. Those women came in before and are continuing to come. We are becoming more effective at getting women who are asymptomatic to come in for screening examinations. And what I'd like to do in the next few minutes is go over with you exactly what it is that we should be looking for when we do these screening exams. The bottom line message of the presentation is that in order to find breast cancer at the earliest possible stage, and that's when we're screening, when they're asymptomatic, you can't wait until the classic radiographic signs appear. You have to learn to look for the earliest possible manifestations. This will enable you to find breast cancer small. It will enable you to find breast cancer when it's most curable. But it also has downside. And the downside is that when you rely on less than 100% reliable criteria, you do have a significant number of false positives, perhaps even a higher number of false positives than you would get with the more classic criteria. If we'll get the slides on, lights down, we'll begin to see exactly what it is that I'm talking about. There are indeed both conventional and special, or if you will, indirect signs of malignancy. The conventional signs are the ones you find in the textbooks. You can find very small breast cancers with these signs. The special signs are much less specific, much more commonly due to benign disease, but can be the only X-ray features of a breast cancer. Now let's first go quickly over the conventional signs and see how during screening both masses and calcifications tend to present. They certainly can present in textbook fashion. You are looking at breast cancers detected during screening in asymptomatic women, which happen to have very ill-defined spiculated margins. The one on your left is done by film mammography, the one on your right by Xerox mammography. They look exactly the same, different patients. But you can find breast cancers by screening that look just like textbook. It's generally easier to identify these cancers on a film mammogram if the breast is mostly fatty in density, because the contrast, the broad area contrast of the film mammogram allows the mass to stand out from the background of breast fat. On a Xerox mammogram, it's a little harder to see when you have a basically fatty breast, yet a small spiculated mass. There is a small spiculated mass up here, a 5-millimeter carcinoma. But it's a little harder to see because you don't have as much contrast to work with. The denser the breast becomes, and this is a problem as we screen in younger and younger age groups, the denser the breast becomes, the harder it is to find the poorly defined mass of carcinoma. Look carefully on the slide on your left, and you'll see that there is a suspicious lesion here. Fortuitously, it is partially adjacent to breast fat. The upper margins are adjacent to breast fat. The lower margins are adjacent to fairly dense breast tissue. Right up at the top you can see spiculations. On the bottom you don't. That's because the spiculations are really well seen only if immediately adjacent to fat. Look at the Xero mammogram on the right. This is a different patient. Again, we have a small breast cancer, partially adjacent to breast fat where we do see the spiculations quite clearly, and then partially adjacent to an overlapping or immediately proximal area of dense breast tissue, and the spiculations are partially silhouetted. So the denser the breast, the harder it is to see a poorly defined mass, especially the classic X-ray feature of spiculation. That doesn't mean you can't find a lesion. You can find a lesion. In a zero mammogram, you can find it because there still are coarse strands that you see radiating out from the lesion, and we'll talk about those in just a minute. In the film mammogram, occasionally you will see these coarse strands, but in addition, you often will pick up the cancer because it appears whiter or denser for a given size than benign breast tissue, which is almost by definition less compressible and therefore looks lower in density. Now this is the way that we often see breast cancer when it presents on screening, before the mass develops its spiculations, when it simply is ill-defined. This is a breast cancer. It's an invasive carcinoma. 6-7 millimeters in size. This is the typical presentation, not the atypical one, where we just have ill-defined margins. You must see your lesion on 2 projections before you call it abnormal and suspicious. But don't wait until you see spiculations. If you do that, you're going to lose the window of early detection that mammography provides. Occasionally you will see a mass, and this is another carcinoma, that has some well-defined margins. Can start out with very well-defined margins before they begin to become ill-defined. In this case, we have some well-defined and some ill-defined margins. Always act on the worst-looking part of the lesion. If you see some ill-defined margins, those are the ones that you go after. Clustered calcifications, again, can be textbook in appearance. The typical breast cancer presenting with calcifications occupies a small segment of one breast, and then when you look at the calcific particles, which are tiny, and look at them closer up, as in this enlarged view, you will see that they vary in size and shape and orientation and density. And especially when you analyze the shapes of the calcific particles, you will be able to see linear and curvilinear and branching forms in the classic example of carcinoma. Now that's a classic one. That doesn't present any problems. That's what you see in the textbooks. What about when the breast cancers become smaller? Well, the first case was a breast carcinoma that was about 1 centimeter in size. This one's about 5 millimeters in size. Still, you can have the typical malignant shapes, linear, curvilinear, branching shapes with calcifications that vary in size and density. They can be typical, but they also can be indeterminate, and they can be very difficult to identify. The problem becomes one of perception rather than one of image analysis. If you look carefully at the slide on your left, this is an overview of the mammogram. It'll take you a long time before you hone in on the area of interest, which happens to be right in there. I've made it easier on the slide on the right by enlarging this section of the mammogram so that you can see this tiny cluster of indeterminate calcifications. Why are these indeterminate? Well, there's enough of them to form a cluster. There's 5 or more of them in a small area. But the shapes are nondescript. They are not linear, curvilinear, or branching. They are somewhat different in size and density. You don't have to wait until you see classic calcifications before you call them suspicious for malignancy, and you should not do so. When you see a cluster of indeterminate calcifications, raise the suspicion of malignancy. You will be correct approximately 25% of the time. Needless to say, we can identify breast cancer by clustered calcifications even when it is very tiny. This is a 2 millimeter carcinoma with just about 5 calcific particles. And by good fortune in this woman, one of them happens to have that linear shape. But even if it didn't, a tiny cluster of calcifications like this should be viewed with some suspicion of malignancy, and a biopsy should be done. Now I want to venture away from the conventional signs into the special signs, the more indirect signs of malignancy that we have to learn to act on if we're going to find breast cancer as early as possible. Some of these indirect signs are more important than others. The single dilated duct is probably the least important of the ones that we will see because it accounts for breast cancer rather infrequently and because it is such a non-specific finding. Nonetheless, it can be the only X-ray feature of a breast cancer. How do we recognize a single dilated duct? You look for a water density ductal structure. How do you know it's a duct and not a blood vessel? Because it starts out biggest where the nipple is and it gets smaller as it branches into the parenchyma as it proceeds distally. You have to see it on two projections. Make sure as you follow it back to the nipple that you see only one dilated duct. If you have a single dilated duct, then it's an abnormal finding and it must be explained. There are a variety of ways that you can go about explaining it. One of which is to do ductography, which is a useful technique if you have the skill to do it and if the patient happens to have nipple discharge. If there's no nipple discharge, you can't do ductography. Beyond that, your only armamentarium, and these lesions usually are non-palpable, is either spot compression magnification views, which may or may not help you to a specific diagnosis, or biopsy or follow-up. The denser the breast, the harder it is to see a single dilated duct. This is a basically dense breast, and we can pick up the dilated duct, and you can follow it back to the nipple, only with some difficulty on the lateral projection. It's a little bit easier on cranial-caudal view. Now, how do we work up these lesions? Well, the best way to figure out how to work up the special signs is to understand the frequency with which they appear and the likelihood of malignancy that they carry. The single dilated duct accounts for only 1% of the non-palpable breast cancers that we find, the cancers that we find during screening. So it is not a common situation. Furthermore, a very small percentage, it ranges from under 1% to as much as 10% of these lesions turn out to be malignant. So with most of these things being benign, and with very few of them actually accounting for breast cancers, the usual approach to this lesion is one of periodic follow-up rather than immediate biopsy. Now, it's true, if you follow these lesions and you have enough of them, sooner or later one of them will turn out to be a breast cancer. But if you follow them closely, you will see an interval change, and the biopsy will occur at that point. Obviously, when you have a single dilated duct, you should image carefully in the rest of the breast, especially that quadrant of the breast to which the dilated duct leads. Notice this case in point. There is a single dilated duct, which you can see on both craniocaudal and side view, but if you look carefully, distal to the dilated duct, above it on the lateral projection, and lateral to it on the craniocaudal projection, seen better on these photographic enlargements, is a poorly defined area of increased density. Perhaps that qualifies as a poorly defined mass. If it does, you'd probably biopsy the mass on its own. But if it's just a vague density that ordinarily you'd leave alone, this finding plus the dilated duct is usually enough to prompt the biopsy, where either finding alone would not be. So when you have a nonspecific finding like single dilated duct, look carefully elsewhere in the breast to see if there's enough to get you to surgery, or whether, without any other findings, the appropriate management would be follow-up. Every once in a while, not commonly, a single dilated duct will be accompanied by internal microcalcifications. This is the most full-fledged example of this that I've seen, where the single dilated duct is jam-packed with tiny clustered calcifications. You would do the biopsy on the basis of the calcifications alone. It's just an indication that when you have a slightly worrisome finding, one that would ordinarily put it into a follow-up category, that any additional finding kicks it into the more suspicious levels where a biopsy should be suggested. The next among the special signs is a particularly important one. It's called architectural distortion. What do we mean by this? Usually we are talking about areas within the breast where you can see stranding, linear markings that radiate out from the central point. If you look right in this region, you can see lines coming out from a central point. Usually this finding occurs in the dense breast. And when it is due to carcinoma, often there's an infiltrating carcinoma, the mass of which is not seen because the margins of the mass are silhouetted. The spiculations are not seen because these too are silhouetted. All that we can see are the coarse strands that come from the distortion of the parenchyma by the desmoplastic reaction of the tumor. And this takes on the X-ray appearance of architectural distortion. Coarse strands, not the fine ones of spiculation. Unfortunately, this is a non-specific finding. You can see it post-surgically. You can see it with radial scar. You can see it with a variety of infectious and inflammatory conditions after healing that produce scarring. How do we act on it? Well, the first decision that you have to make is, do I have a mass associated with it or not? If there's a mass associated with it, if you believe that you can see a mass associated with all this coarse stranding, and this is just a photographic enlargement of the same thing, if you think there's a mass, then by all means do a biopsy. Because a mass plus architectural distortion is two findings, and that's enough all the time to do a biopsy. Study this case for just a minute. Notice how dense the breast is. This breast is almost uniform dense tissue. If you look really carefully right in this region, and it's photographically enlarged on the slide on your right in the center, you'll see some coarse strands coming out from the bottom of what may be a mass. Now there's a little bit of hallucination in here in order to see that as a mass. But clearly there are strands coming out from a central region. The denser the breast, the harder it is to see the mass. When you see these findings, especially if the strands are finer rather than coarser, always suggest a biopsy. This turned out to be an infiltrating duct carcinoma that was almost completely silhouetted by the dense tissue, presenting with either slightly coarsened spiculations or early architectural distortion. This is a borderline case between the two. There's a continuum between spiculated mass and architectural distortion. When you get areas of architectural distortion that happen to exist right at the interface between subcutaneous fat and parenchyma, then you will find a distortion of that normal interface. Normally the interface has rather smooth scalloped margins, like you see up there and like you see down here. Notice that when there is distortion of the interface, you start seeing strands coming out every which way. So architectural distortion can be seen not only because it causes strands radiating out from a central point, if the lesion is embedded within parenchyma, but also because it distorts normal parenchymal fat interfaces if it happens to be superficial in location. If you find this, of course, proceed to another right-angle projection and identify the same abnormality so that you have enough to proceed with needle localization and biopsy. Because architectural distortion in and of itself, although non-specific, usually gets biopsy. Not always, but usually it gets biopsy. Why is this? Well, first of all, it accounts for almost 10% of non-palpable cancer, so it's a rather common finding. In addition, 10 to 15% of these cases prove to be malignant. Now, some of them can be explained away by appropriate history. If you've got appropriate history that indicates prior infection, inflammation, or trauma, and you have an old film, especially, that shows that the appearance of this finding relates temporally to that trauma or that infection or inflammation, then you can explain away the architectural distortion and you can save a biopsy. What is left after explanation of history often will result in a higher percentage than you see here. And that will justify a biopsy. So get a good history on your patients, get very good quality images, and consider doing biopsies for architectural distortion because it is a rather common way in which non-palpable breast cancer can be found. Now, the asymmetric density also can be the only and the earliest X-ray presentation of carcinoma, but this one is much less commonly biopsied. Not because it's an uncommon finding, but because it so typically is a benign normal variant. What do we mean by asymmetric density? Well, this is a gross example of asymmetric density in the breast. The left-hand breast on the images that you see is a lot denser than the one on the right, especially in the upper outer quadrant. How does one distinguish an asymmetric density from a poorly defined mass? Look at its margins and look at its central density. The margins of normal breast tissue tend to be scalloped or concave outward. The margins of a mass tend to be rounded or convex outward. This one has concave outward margins. So it's more likely to be asymmetric breast tissue. Then, next, look at the density within this area. If it's a mass, if this whole thing were a mass, you would expect that the central portions would be densest and it would be less dense as you get towards the periphery. Well, that's not the case here. This lesion seems to be interspersed with fat. And that's the typical appearance of normal breast tissue, albeit asymmetric breast tissue. So if the margins show concave outward contour and the lesion is interspersed with fat, it's an asymmetric density rather than a poorly defined mass. And we see that shown here. Here's another example. This one is a little bit closer to a poorly defined mass, but not quite there, because even though on this view it looks like maybe there's a mass, when we get to the right angle projection, we see that the area is interspersed with fat. Another asymmetric density in the upper portion of the right-hand breast. Let's look at this one up close. And this is another thing that you're probably going to want to do when you encounter the asymmetric density. You want to get a spot compression mag view. Look at its borders. Are the borders basically rounded? Is the lesion interspersed with fat? If your judgment is yes, then call it, if your judgment is that it has concave borders and it's interspersed with fat, call it an asymmetric density. If it has convex borders and it has central density, then call it a mass. Masses get biopsied. Asymmetric densities usually do not. Why? First of all, it doesn't account for that many non-palpable breast cancers, but even more importantly, very few asymmetric densities prove to be malignant. It's hard to justify the biopsy of more than 100 cases in order to find one breast cancer. And that's what the statistics show for asymmetric density. It's a common normal variant, but it rarely indicates breast cancer. How do we manage these lesions? Usually with periodic follow-up. Our follow-up protocol is to have the patient come back in 6 months and then yearly for 3 years, although the follow-ups that you'll hear from different people will vary. Basically, you want to get an early follow-up and then some more prolonged examinations to demonstrate radiographic stability. Remember, in dealing with asymmetric densities, that usually when there is a breast cancer, it's not the whole asymmetric density, it's just part of it. So if you have to biopsy the asymmetric density, you have to biopsy the whole thing. Not just a little bit of it, but the whole area. Since these lesions tend to be fairly large when we recognize them as being asymmetries, you're talking about a very substantial biopsy with a very low yield. That's why we generally follow them instead of taking them out. One important correlate when you're dealing with asymmetric densities, always suggest or yourself conduct a retrospective physical examination, because those few asymmetric densities that turn out to be malignant often will show a palpable thickening in retrospect. Even though the patient presents without any palpable finding, in retrospect sometimes you can find something. And if you have a palpable finding in addition to the asymmetric density, you may well want to proceed with a biopsy, where if it rests non-palpable, then you'll put the patient in a follow-up group. As with any of the other indirect signs, if you are considering follow-up rather than biopsy, look carefully for additional X-ray signs. Here's an asymmetric density, and it's partially interspersed by fat, but notice the stranding that's coming out superiorly. So this stranding plus the asymmetric density should raise additional concern and prompt a biopsy, where the asymmetric density itself probably would cause a follow-up exam. Now, our final indirect sign is called the developing density sign. Some people call it a neodensity sign. What is this? This is the finding on a subsequent study of an area of increased density where none was present previously. An initial mammogram with basically normal appearance, a subsequent mammogram, and lo and behold, there's a new density right here. Any developing density is abnormal by definition because the natural history of the breast is one of progressive fatty replacement. Except for pregnancy, lactation, or exogenous hormone treatment, we should not be seeing increased density in the breast. And if you don't have one of those things to help explain it away, then you have to come up with an answer of why there is a developing density. They can be easy to see as that previous case, or they can be very subtle. Developing densities are probably the hardest things to perceive. Compare these two mammograms, for example. The one on your left was the initial study. The one on your right, the subsequent one. If you look very carefully, you may begin to appreciate some increased density right here where it wasn't quite that compact there. Now that's subtle. Most people will not see it. In fact, when we viewed these two examinations together, we didn't notice the developing density. This is too early to call, although visible in retrospect. What happened? She continued to have screening mammograms, and she came back next time with a more obvious developing density. Which brings me to an important point, which you will see time and again as you do more and more breast cancer screening. There will be new lesions that appear. As you have old films to compare with, you will identify these new lesions because of change, but you also often will be able to go back to that initial study or the one just before the examination which points to the lesion and see some vague origins from which this lesion arose. That does not mean that you made a mistake by not calling it the first time. Probably there was insufficient evidence, radiographic evidence, to act on initially, and only after the developing density became a little bit more obvious could you proceed. We have noticed in our screening series that about 30% of our breast cancers were visible in one way or another in retrospect on a prior exam. Now that does not mean that these cancers should have been called on the prior exam. In none of these instances was there enough, even among the special signs, to give a call for biopsy. But if you see or you think you see a developing density, then the appropriate next step is to get some additional pictures and to try to demonstrate it on two projections. Once you've found the developing density, then appropriate management usually will turn out to be a biopsy. Developing densities can be easy to see from a distance, where from up close they may be hard. From a distance, this tiny little area of increased density becomes really obvious. When you get up close to it, it looks like nondescript breast tissue. But clearly it was not there before. That's abnormal. When we did a spot compression magnification view of this region, we saw some poorly defined margins, and we had enough because we could find it on two projections to suggest a biopsy. Why do we suggest biopsies for developing densities? For a variety of reasons. First of all, it accounts for a sizable percentage of the non-palpable cancers. Secondly, a reasonably large percentage of these lesions turn out to be malignant. Now, obviously, not everything that appears in an interval is going to be a breast cancer, because benign lesions grow just the same as malignancies do. But 10 to 15% of developing densities turn out to be cancer. And if you think about it, what is the alternative to biopsying a developing density? You're certainly not going to ignore it with numbers like this. The alternative would be follow-up. When we follow a lesion mammographically, what causes us to suggest a biopsy is interval change. a developing density by definition has already changed because it wasn't there before and it is there now. So when you see a developing density, think seriously about a biopsy, assuming that you can identify the lesion on 2 projections. Now, developing densities can be easy to see and they can be hard to see. They're harder to see when you have a lot of vague shadows in the breast. This woman has about 5 or 6 little 5-millimeter nondescript nodules. And this was her initial examination. None of them looked different. They all looked about the same, so we didn't do anything about it. She came back a year later, and all of a sudden one of them's a little bigger. That's a developing density. Because this one changed disproportionately to the others. Developing densities are hardest to see when you compare film with Xerox mammography. And often, in these circumstances, you fail to notice them. This woman had a 0 mammogram and then a subsequent film mammogram, and there is an added density here, very nondescript in nature, which was not present there. Wasn't recognized either because of the subtle interval change. And we had to wait past this demonstration until it became a little bit more obvious because it's easier to compare film with film exam than film with Xerox exam before we could identify it. Fortunately, the lesion is still small. Fortunately, the lesion was completely excised. The patient has done well now, about 7 years after excision, so chances are she's been cured. Now, to summarize the point of what I've been talking about for this last half hour, the mammographic features of breast cancer as found by screening can be really obvious, but that's the exception, not the rule. The rule is look for less than classic signs. If you've got a mass, look for poorly defined margins rather than spiculations. If you've got calcifications, look for nondescript clusters rather than clusters of very typical shapes. And remember your special signs. If you add the percentages of each of the special or indirect signs of malignancy altogether, it turns out that about 20% of breast cancers can be found only with the indirect signs of malignancy. You would do your patients a disservice if you ignored these features and you simply waited for the conventional signs to exist. Thank you very much.